We are now live.
Thank you very much. Welcome to a virtual meeting of the External Services Select Committee at the London Borough of Hillingdon. This virtual meeting is also being broadcast simultaneously on the Council's YouTube channel Hillingdon London. The purpose of this committee is to monitor Council services and their performance within its remit and undertake in-depth reviews and witness sessions on topics, submitting any findings to the decision-making cabinet. My name is Councillor John Riley and I'm the chairman of this committee. Online housekeeping. Before we start, some important online housekeeping for everyone present. Please ensure that any mobile phones around you are on silent and that any home listening devices like Alexa and so forth are turned off. Please keep your microphone muted when not speaking and then unmute to speak. As chairman, I will call on those to speak during the meeting. And for everyone present, because we're on this particular platform, just raise your hands somewhere near your face so that I can see that you're indicating that you'd like to speak. If you raise your hand to the left or right, I can't see. In terms of technical meeting control, if any councillor leaves the virtual meeting partway through or for a period of time or has a lost connection, I'll continue the meeting unless we are not quorum, which is 5 councillors, but we are at the moment. Before we go any further and go on to the agenda, I'd like to do a roll call of all the councillors and other persons present to confirm attendance. Please indicate you are present when I say your name. Councillor Nick Dennis.
Good evening, Chairman. I'm present.
Thank you. Councillor Simon Arnold.
Good evening, Chairman. I too am present.
Thank you. Councillor Stuart Mathers.
Good evening, Chair. I'm present.
Thank you. Councillor Ali Malali.
Evening, Chair. I'm here.
Councillor Devi Radia.
Evening, Chair. I'm here.
Thank you. Nick Hunt from Royal Brompton Harefield.
Thank you, Chair. I am here.
Thank you. Boyd Fisher from London Ambulance Service.
Good evening, present.
Vanessa Odlin from CNWL.
Good evening, Chair. I'm present.
Thank you. Caroline Morrison from Hillingdon CCG.
Good evening, Chair. I'm present.
Thank you. Jason, I think you've just arrived from Hillingdon Hospital. Are you here?
Yeah, apologies, Chair. Just a few login difficulties.
No problem. Dan West of Hillingdon Health Watch.
Good evening, Chair. I'm present.
Thank you. Thank you. And Nikki, well, I can see her. She's sitting opposite me.
I'm here.
Yes. All right. So we can move on to the agenda. Apologies for absence.
Chairman, we've had apologies from Councillor Vanessa Harangi and from Councillor June Nelson.
Thank you very much. Declarations of interest in matters before this meeting. I'll take it that there are no interests unless anyone actually does declare. All right, exclusion of press and public. All items are considered in part 1, but there are no part 2 items. And first of all, then, to receive and agree the minutes of the meeting on the 8th of October. You've all seen those, fairly detailed and as ever and lengthy because of the nature of the meeting. I shall take the minutes as agreed unless there are any suggested amendments from anybody. Anybody? No. Okay, I'm getting shakes of head everywhere. That's great. Thank you. And can we take those as agreed? Yes, I think we can. Nodding would be good. That's it. So the main work of the evening is agenda item 5, the health updates. We will take them in an order that we've set out and agreed. And I think the first one is Nick with Royal Brompton.
Thank you, Chair. Apologies for the slight delay there, trying to find my microphone. I thought it would be helpful, I'm happy to take other questions, to give this committee chair an update on where we are with COVID and the impending merger with Guy's and St Thomas's. As you know, we are still awaiting the sort of full force in London of the second wave. We are currently, as a trust, we have 14 patients with COVID, 11 of whom are on full life support on ECMO. And of those, there are 2 at Harefield, but neither of whom are on ITU. They're on a more general ward. Just a quick comparison, at the height of the first wave, Harefield had about 40 COVID patients. Brompton about the same. So we are only at the foothills of this particular surge as we speak. Although bizarrely, we've actually got 15 people on ECMO as a whole. So we've got a lot of flu cases coming in as well as COVID. On the merger, both trust boards have met and considered a business case, which has been approved. NHSEI have said that they're not going to do any more scrutiny of it. So the next formal stage is the completion of the Cheapy exercise consultation, which is currently going on, and both sets of governors to consider the gets a bit complicated. They're not actually considering approving the business case. They have to consider their approval of whether the boards have conducted themselves in a proper and well-governed manner in order to reach this decision. That will happen in December. And then the current planned date for merger is February the 1st, 2021. You will know, as councillors, I'm sure, on your own grapevine, that the Royal Borough is unhappy with this proposed merger. We're not. We see some vast benefits from it, not least for the amount of shared information we'll have. I mean, it'll be a £2.5 billion enterprise, this. So the potential benefits for patient care and academia about being able to share information across such a wide organisation, we think will be beneficial to the whole. More reassuringly, it doesn't change what Harefield does in any way, shape or form. And I suppose, and it's not betraying a confidence here, I would characterise Harefield as being more relaxed about the whole enterprise than colleagues at the Brompton are. Because for the obvious reason, there's no proposal for any services at Harefield to move. In fact, I mean, the likelihood is, and I think I've said this before, that once the building costs of a new building at Westminster become apparent, I'm sure they'll probably try and expand services at Harefield. Happy to take any questions.
In the absence of Councillor Nelson, whose special responsibility this one is, loads of rumours flying around, Nick.
I'm sure.
That range from Harefield is closing, which we've, pretty much stamped on, because at least you'd have told us that if it was going to happen, but more encouragingly, that Harefield is going to be possibly increased in responsibility and so forth, but also some sort of connection with Chelsea and Westminster as against Guy's and Thomas's and sort of empire building and power grabs and all the rest of it.
Certainly, there's been a recent few months of Northwest London being one of the more ambitious of the new ICSs, and there has been a bit of discussion about what services remain in Northwest London, which go. I think it's important to remember that a proposed build, which would take a relocated cardiovascular service from the Brompton, combine it with that at Guy's and Tommy's at Westminster Bridge, is but a twinkle in the eye at the moment. So we're talking at least 10 to 15 years before such a building would be there. And that doesn't even mean that necessarily someone won't find other uses for the Brompton as a hospital site. Harefield is also, you'll know, under consideration for a potential transfer of the cancer services from Mount Vernon, and which is under consideration by the eastern region of NHSEI. And as I said, Harefield's not going anywhere near closure. I mean, I think we just have to remember that most of the people currently working at a senior level in Northwest London, me included, might be invited to the opening ceremony for this building, but it's going to be way beyond our retirement.
Oh, let's hope not. I suppose the other thing is to flesh out a little bit about, you said that you could, obviously there is quite strong opposition, either politically and or locally, in terms of residents in Chelsea and Westminster. But you see advantages and significant advantages in the merger. Perhaps you've talked about sort of knowledge base and things like that, but perhaps if you could flesh that out a little bit so we can understand how that works and how you see that.
I think there are probably three or four things. One of the advantages is that we will be tapping in academically to both Imperial and King's College. So we'll have a wider expanded academic base. The second thing is, and I must admit, I hadn't really appreciated that until the consultation on Cheapy came out, was that a lot of staff see this as a huge example of being able to move around in the same organisation and, and for their careers to expand. Harefield and Brompton are small places. We employ 3,000 staff. Moving into an organisation which might be sort of nearer the 20 plus, and the fact that Guy's is not just a specialist centre, but it also provides community services and DGH services, makes it a much more attractive potential proposition to apply for jobs in advance. We've already started a number of joint services. So our transplant clinicians run clinics at Guy's and Tommy's. They have under their auspices a big cystic fibrosis service, so that will benefit from the lung transplant expertise at Harefield. And to put it on, I suppose, on a very broad basis, we are together going to purchase a patient administration system called EPIC, which will be able to define what the best treatments are by studying a much wider range of patients more quickly. We will also have, frankly, pretty big purchasing power and quite a lot of influence over cardiorespiratory services. I suppose the final thing is that the move, and there will be an earlier move on our paediatric services to the Evelina hospital. This does make us compliant with the congenital heart disease review decision back in November 2017, that paediatric services must be co-located with others. So that fulfills that requirement.
Yeah. Okay. And as you were saying, there's no immediate concern in terms of the Brompton itself, because you're going to need that building and people in it and the services in it for some time yet, because the new building, as you say, is some long distance off.
Oh yeah, well, I mean, there's no outline business case. There's no, it's nothing, as I said, but a good idea at the moment.
All right, thank you. Anybody else got any questions on this one? Looking around, no. Okay, that's great. Well, I know you'll keep us up to date on that, and we can happily go around koshing rumours about all sorts of terrible things not happening. So that's great. Thank you very much, Nick.
Thank you, Chair.
Thank you. All right, the next one on the list is Boyd with London Ambulance, and thank you for coming along.
Can you hear me okay?
Can now, yeah.
Thank you very much indeed. Thank you for inviting me, Chair. Obviously you knew Natasha Wills. I've taken over as area lead now for Natasha. So just introducing myself a little bit. I've worked 25 years, 20 on frontline, so much now, just go out as and when really days. Lived in Hillingdon most of my life, and worked road Hillingdon most of my life. So I have a strong connection with Hillingdon and a lot of affection for it. I moved out to Marlow 5 years ago. So before that I was in Ickenham for many years. So I'm very, very keen, very honoured to come and talk to you this evening. Nikki, I did some slides. I don't know whether you're able to put those up or not. Thank you. Could you just go to the next one? Just as a bit of an aid member. Thank you very much. I guess you'd like to know about our COVID response. One of the things that we did, we moved to 24/7 senior management cover. The benefits of was it ensured direct briefings to the staff. Staff were quite, when COVID first started, we weren't used to wearing Tyvek suits and masks and different masks for different types of calls. And so it was important that there was visible senior management leadership around. So we found that helped. Also, direct instruction as things changed, which they did a lot, particularly in the early days, from Gold, which was sitting, was passed through the local senior management to our team leaders and staff. We had we entered into a joint relationship with the London Fire Brigade. London Fire Brigade worked out that they weren't going to be particularly busy over COVID, and we had over 300 London Fire Brigade volunteers work with us. They were absolutely fantastic. The way that it worked out, we had so we'd have a clinician on the vehicle, and the fireman would drive. And they were so helpful, so supportive to the crews. It was almost without fail. It worked really, really well. And we've continued since then, a much scaled down version, but we've still kept that going there. And I think the firemen like it for development themselves. So it worked really well. We also took, as I'm sure my other NHS colleagues did, we took volunteers in. Many different backgrounds. We had them helping in such as logistics, and there was some really, again, some fantastic people that came in that were furloughed, but rather than just sit at home, which they could have done, they decided to come in and do some other things. And from a personal point of view, I've picked up an excellent business support manager from this. She just came in to do some logistics work, just helping moving things around, but she's really high quality, and I've now got her in full time. So there's been a little bit of a dividend there for us on that as well. Station consolidation, I'm sure you will have heard a little bit about that. We moved from 68 sites to 41 across London. The idea of this was for better access to management again, so that there was more visibility. PPE supply, again, it was a bit patchy at the start. We had enough, but where we had say 5,000 or 15,000 of one sort of mask, we didn't then have the opportunity to buy another 15,000 of that mask. We had to go to a different company and things like that. So there was a lot of different things we had to do. First of all, moving around, and of course, it all required different training, different fitting of these masks. They all have to be tested, other than the basic ones you see we all wear, people in the high street, the sort of blue ones that go around your ears. These are proper sort of rubber fitted ones that are used in certain types of jobs. The station consolidation also helped single staff pairing. So we anticipated very high levels of absenteeism. Actually, it didn't come anywhere near as badly as we thought. We ended up, the worst we got to on frontline staff was about 30%, and we thought we would get to at least 50%. So with the benefit of the LFB, the fire brigade that we brought in, we didn't really notice. We didn't really notice it at all. In fact, we had extra vehicles, so that all worked well. And of course, the other thing, it helped us with welfare, staff welfare. There were people at the time. We understand a lot more now, but there were people at the time that they lived with someone that had suspected COVID. Should they come in? Should they go home? Should they go home now? You know, there was all these sorts of things. So that sort of reassurance to staff really worked quite well. As I said a bit about the PPE there, there's largely two types. There's the type that we use for serious jobs, where we've got effectively an advanced airway used on an individual, on a patient, but otherwise it's a straightforward, as I said, sort of mask you see in the high street, and just like a sort of pinny thing, a plastic pinny really. Another thing, just to mention, that what we call our PVR, peak vehicle requirement, we usually across London put out around 320 vehicles, and over COVID we got that up to 500 vehicles a day. So that was an astronomical achievement, really. I feel to get that. Could we go to the next slide, please, Nikki? So I just wanted to give you an idea of what our performance has been in that time. So we could have taken the performance from anywhere, but I've done it right from the start of effectively our financial year to when I run this off on the 5th. So if we look if we go through it, the C1 mean time of 6 minutes average in that time, we're allowed 7. The C2 mean time of 12 minutes 29. We're allowed 18. The C3 mean in that time, we've got 30 minutes there, we're allowed 2 hours. And the C4 mean, we're allowed 3 hours, and that's 49 minutes there. So that's the whole financial year so far. So that again is unprecedented, really. Normally, I'm sure Natasha came many times and talked about the good and the bad with performance, but that's certainly much better than we normally achieve, never mind with COVID. So could we go to the next one, please, Nikki? So just very briefly, this is just talking about arrival at hospital to handover. Literally, this is Hillingdon, and I know you've got Hillingdon on here, but again, that's a good news story that if we just look over the previous week, we're 9.1% conveyances down to Hillingdon overall, all in the green there. But I don't want to talk too much about that because I know you've got Hillingdon on. If you could just go to the next one, please, Nikki. This in graph form just shows you right across for an entire year there. So the conveyances in the black line are what we've done this year, and the blue background there is the comparable dates of the year before. So you can see that our conveyances are slightly down from where they were. Can we go to the next, please, Nikki? So risks and challenges, stations at capacity. Where we've consolidated, we are cramped. There have been improvements that have gone on to the stations to try and make the staff living quarters a bit better. We've improved showers and things like that, but they're busy. Largely, though, our staff spend almost uniquely in the health world. They spend next to no time at home as such. They're out basically within certainly 20 minutes to half an hour. they're out, they get their first call, and they don't come back to the end of the shift largely. So it's sort of shift change over times, really, when things can get a bit tight. Permanent station closures. We've shut Wembley and Ruislip. North West London NHS Property Services have asked for both properties to be returned to them. Now, the consultation process has now begun. Actually, all the frontline staff have actually been removed. So Ruislip being your particular interest, unless you live in Wembley, then the Ruislip staff for some weeks now have been moved back to Hillingdon ambulance station. So the actual sort of more difficult parts of the process about encouraging staff to move and re-accommodating them has already been done. But we do still have to go through a process over that. As I say, we've rehoused all the displaced staff. Ruislip staff went to Hillingdon. If we felt that performance in an area did drop, then what we can do is we can use what we call active area cover, where we can send staff over to the area, and so they would be better placed to receive a call in that time. Ruislip as a station, as a group of staff, do 0.02% of the LAS work. So it's a tiny amount, and it's something that so far we've comfortably consumed. The next one, please, Nikki. Last one. So superstations we're looking at. Our estate is not really fit for purpose, because although people, as I said, they go out very quickly and they're out most of the day, what we'd like to do, we'd like to be able to do a lot more training on station, a lot more local things, meetings rooms and things like that. And the executive team now have set out on a very ambitious plan to do what they call deployment hubs, what the staff call superstations, basically. That seems to be the name that's stuck. There's no point in calling it something different. The first one is in Romford. So that's largely because they're a big group, and their main station is again being taken back by the landlord. But I'm on the working group for this, and I'm going to push very hard to try and get the second one in Hillingdon. There's no guarantee with this, but I want to try and take advantage of any potential COVID dividend that there is at the moment. We know that historically the Hillingdon area, with the airport on the doorstep, is very expensive for warehousing, which is the kind of facility that we're going to look for. But the way things are at the moment, other people's loss is something that potentially we could, I hope, get an advantage out of, and things that maybe, premises that maybe were out of our reach, maybe won't be now, which would be really nice. As I say, the sort of place that we're going to move into will be sort of warehouse facility that we will adapt accordingly. The timeline for these to be done, the first one is 6 to 9 months, and the idea is that we set a sort of a rubber stamp, a plan that we can do the same thing wherever we go, and then we're hoping to turn out one every 3 months or so. There's 18 to do, so there will be 18 of these across London, completing hopefully in about 5 years. That's incredibly ambitious, but we've done so much over the last couple of years that I've never seen in 25 years within the London Ambulance Service. So I'm hopeful that we can do this. That was sort of what I wanted to say, really, but I'm happy to take any questions now. Thank you, Nikki, for that.
All right, thank you. Well, I suppose I wanted to declare an interest as a Ruislip councillor, or should I say West Ruislip councillor, just to see what the criteria was for permanent closure of the Ruislip base.
So Chair, it was not. It wasn't. So there's two separate things here. There's the consolidation process, which we did, which I think explained about why we did that. In terms of because obviously that facility wouldn't have been suitable to put people into it. We had a bigger facility at Hillingdon that was much more suitable, if that makes sense.
Yeah.
In terms of this, we had no option. We've had very short-term leases. We pay nothing on Ruislip at all. So we've been just. It was a mutually agreeable deal that we knew that they would want to redevelop the site over a sort of short to medium term, and they were happy that we went in there on the basis that we would kind of look after the place. But to be honest, it's been fraught with difficulties. It's as you would know, it's quite a big building, and we only had a very small part of that, and we ended up with kids breaking in upstairs and running around and breaking pipes and things like that, which was quite intimidating for some of the staff that we had there. So it only ever was going to last so long. I did some work some years ago when I was still working at Hillingdon with the LFB to look at us going in and taking part of the Ruislip fire station, and that kind of again would have done. We could have worked something there, but it's not the sort of facility now that is the proposal. It's a much better facility, and we've moved on a lot more about sort of management support, welfare support to staff, and that we're much more involved in that than perhaps we were sort of 5 years ago when I'm going back there.
All right, and the super stations
Yes.
will inevitably, if one is built in Hillingdon, would other properties therefore be closed and utilised in different ways as a consequence of a superstation hub?
Yes. So anything that we own would be sold to pay for the ongoing programme, and other things that we don't own would just be given back.
Okay. The other thing really in relation to COVID of interest, I think, to us would be the way in which people have used the ambulance service in COVID. How have you found people? I mean, has there been I don't say panic, but has there been a greater use of the service because of COVID, or have people largely only used the service if there's been a kind of increase in their view of how their condition is an emergency or not? So in other words, they wouldn't use it just because they had symptoms, presumably.
So the advice is quite strong now, isn't it? About that people know to ring 111.
Yeah.
If they ring their doctor's surgery answer phone will say ring 111, and 111 we run several of the 111. We don't run the one over this neck of the woods, but we do elsewhere. And we've found actually that overall demand kind of stabilised. It's probably even slightly less than normal, although obviously a much more significant percentage of that was for COVID. Clearly, that was a large percentage of that. But I think the message really genuinely got through that actually, if you've got this, unless you're really suffering, then you're not going to get that much out of hospital, and therefore us. So all in all, I think people were generally quite sensible, in all honesty.
Actually, I'll ask the same question of the various representatives of the trust. I mean, Nick, Vanessa as well, and we'll come to you in a minute generally, but and maybe Caroline with a handle on this. But I mean, the whole narrative has been about not overwhelming the NHS, and one hears conflicting stories about the extent to which, and Jason, sorry, one hears conflicting stories about the extent to which the hospital estate, if you like, and the NHS in that regard has or has not been overwhelmed. For example, the use of the Nightingale facilities and the extent to which people were or were not going to hospital. So help us with a sense of how it's affected so far. Let's start with Nick first.
Thank you, Chair. I mean, I think the first thing to say is that we roughly run at about 100 primary cases of heart attacks a month. During the height of COVID, that dropped substantially to, none a day when we'd normally see tons. The reasons for that aren't known. Better air quality, less stress, people not going to work, or the other side of that was potentially people not wanting to bother us and registering too late.
Yeah.
So, it'll be a PhD study in a few years' time about what exactly happened.
Maybe sooner.
Jason,
Jason, just a quick comment on your perspective on that.
Yeah, thank you, Chair. So just following on from that perspective, I think the key piece, if you just look at about emergency attendances broadly during the first wave, emergencies attendances were sort of half what was sort of being seen sort of prior to COVID. I think the key piece about the areas where we had real sort of pressures on our services, certainly around critical care, key piece was everybody working as a system. So looking at Nicholas here, I think a key piece that was not really highlighted actually during wave one, of there probably were a fair few occasions where our critical care department was full, but it was the close relationship, certainly with Harefield, where absolutely, as we were sort of working as a network across critical care, patients were able still to get the best possible care going. But that was very much about how everybody in their critical care departments networked together. And I suppose the piece that slightly changed recently, and everybody's obviously sort of watching for what is being labelled wave two, is in wave one, broadly, we weren't doing, planned care was at minimal levels. Over the last few months, we've sort of obviously started doing a lot more planned care, and it's making sure, however people sort of refer to sort of green or clean pathways, that we've got planned care facilities for operations that are able to continue.
All right, thank you. Vanessa, I will come to your bit in a minute, but just a quick comment on that perspective.
So I totally agree with what Jason said, actually, because in terms of this kind of second wave, obviously I wasn't around in Hillingdon during wave one, but certainly in the second wave, we're obviously being asked to continue with what we consider to be the routine work, as well as picking up the emergency and what we'd consider to be the COVID work. And I think in the first time round, we were able to redeploy a number of staff from the routine work into our more emergency and crisis services, which actually supported with wave one. So I think from my perspective, it's the kind of services part of the part of it, but it's also the staffing part of it, because we obviously are trying to ensure that where staff have to self-isolate and where staff are poorly, we're still able to continue to run all of those services. So I think for me, it's both of those.
All right, thank you. And Caroline, just a quick sort of overall comment about how things have stood up.
I think, I mean, there was a lot of pressure in the system in wave one, absolutely. I think we worked collaboratively really well to try and support where we could to ease those pressures. I would say just in terms of primary care, where we really felt the challenge to start with particularly was the access through 111 and some of the challenges that we had in terms of just sheer volume of people contacting. And actually we got to a point where we saw the contact sort of switch from being primarily to 111 into primarily to primary care. So there was a point at which in the pandemic where people sort of made the decision to contact their practice rather than to contact 111, partly probably because an element of that was follow-up, but partly because I think there was a sort of concerted effort from practices to start managing COVID symptoms in general practice. And as Vanessa was saying, certainly in wave 2, the work that we are doing on the ground collectively with partners, but also from a primary care perspective, is to maintain as much of that planned care in primary care as possible, as well as managing the pressures that we're feeling from people who are increasingly symptomatic in the community. So that's the challenge for us really going forwards.
Okay, and certainly a lot of experience with regard to pharmacies and the extent to which they were being, I mean, they really took or soaked up, I think, a great deal of patient concerns. Certainly going around, because a number of us did sort of med deliveries and different things early on. And it was pretty obvious that people were using pharmacies as a sort of line of first resort, especially when things were a little difficult at the start as to knowing where to go, as it were, and where to get access from. So, well, look, that's really interesting. Thank you all for that. All right, Vanessa, you're up, and welcome to the meeting. Vanessa is the representative from CNWL, and replaces Maria and other friends and colleagues who've been with us for quite some time. So welcome, and we'll hear your presentation. Thank you.
Thank you. And for those of you who don't know me, my role is the Director for Hillingdon and Mental Health in CNWL. It is a new role in CNWL, and yeah, really excited to be here. Bear with me, I'm 3 months in. I think I've got a presentation, so I'm hoping that, is it Nikki who can help? Lovely, thank you. So if you move on to the next slide, please, Nikki. So I'm going to try and, in a short space of time, cover the range of services that we cover in Hillingdon. So if you move on to the next slide. And I'll try and pull out some of the kind of areas of focus. I think rather than talking about COVID specifically, what I would say is that actually all of the transformation and all of the work we've been doing, we're trying to kind of weave all of that through that. So every time we're thinking about transformation, or every time we're thinking about changing our services or doing a piece of work, we are thinking about the impact of COVID on that. So I would start by saying that actually this slide should say community health services. It covers adult and older adult services. So this is the physical health community services as part of CNWL in Hillingdon. Our main focus at the moment is focusing on discharging out of hospital. What I haven't added in, but one of the areas of focus we have at the moment is we've set up a daily call within the system, so encompassing all of the various partners in Hillingdon, so we can all work together to focus on how we can ensure people are discharged out of hospital in a really timely way and when it's clinically appropriate. I've detailed some of the services that we've set up in the last over the last 12 months that we've put in place, because we believe those are services that will support discharge out of hospital. So I won't particularly go into those, but if people have questions at the end, they can ask me and I can try and answer some of those. But as I say, the main focus has been for us how we kind of pull people out of hospital into the community. Next slide, please. So we also in Hillingdon cover mental health. So what I've tried to kind of lay out here is some of the new services that we've put into place over the last 12 months. You won't be surprised to hear that our focus in mental health is also ensuring that we can keep people in the community as much as possible, and that we use our hospital resource for people who do really need that. So some of the funding that we've had available to us, we've put into focusing on our community services. So we've focused on our first response service, offering crisis support for patients, or crisis assessments for patients. We've people may and hopefully have heard of the Coves, which is a new crisis haven that we've set up in the last 3 to 4 months, which is provided by a third sector organisation in Hillingdon. If you haven't heard about it, then I'm really happy to kind of talk more about that, and because I really want to make sure that that's a service that we're making the most use of. That's available to all Hillingdon residents, and is set as more of a non-clinical therapeutic space for people to get crisis support. The last two kind of areas of focus from our transformation over the last 12 months are particularly around having a centralised way of supporting finding a bed when that's needed, to kind of eliminate the number of times that people have to tell their story when they need a bed, and that we can be as efficient as possible, and to ensure that we treat people as close to home. So I realise we've used some jargon in the slides as well. So OPES is out of area placements. So that's where, if there isn't a bed locally, we would be looking for a bed in another provider somewhere in the country. So we try and obviously as much as possible want to keep people as close to home in Hillingdon, in our hospital. We're also just launching a trauma-informed approach in our inpatient services, so that we can ensure that we've got therapeutic wards when people are in crisis and do come into hospital. Next slide, please. So I've focused on some of the things that we've done, some of the things that we're doing now and for the future in terms of mental health. We're looking to develop what we're calling a one-stop shop. So something similar to the Coves, but actually it's for people. We want something for people when they're not necessarily in crisis, but they're just looking for some support or some help. We'd like to be able to open up, have a kind of open access service somewhere in Hillingdon for residents to come in. So they may just be looking, they may be just worried, they might be looking for some wellbeing, they might be looking to be signposted to various services. So that's certainly a kind of real passion of mine, to make sure that we are treating or supporting people kind of really at that front door, rather than waiting for people to get so poorly that they're accessing either hospital beds or kind of secondary mental health services. Our second point is around complex rehabilitation, and we're working with the local authority to ensure that we can provide rehab services, and again that we treat people in the least restrictive environment. So if that means people that we need to look at more placements in the community, we're kind of just at the start of looking at that. And our emergency and urgent access, I've already kind of talked about that in the other slide, in terms of the support for crisis, when people are in crisis. Next slide, please. So moving on to children's services, I think the one thing that I wanted to pull out of here was around the health promotion groups that our children's services have set up, which have been really good. So using digital platforms to reach parents in terms of health promotion groups, as we've had excellent feedback from. And I think even post-COVID, when that happens, that we will continue to do digital health promotion groups, because it has meant that we can access a larger range of parents. The other focus has been around our health visiting teams, ensuring that they're routinely asking parents about where their baby sleeps, to ensure that they can have individualised care planning. Next slide, please. So I'm going to talk a bit about CAMS. Our performance, you will see, has ranged. I'm pleased to say that they are achieving the target, but what I would say is that we are always looking to improve and to ensure that we are assessing and seeing children who require mental health support in a really timely way. In in wave one, we did see a huge impact on the CAMS team actually from COVID. So we were unable to always meet those targets. So we did have a dip there, but I'm pleased to say that that's back up and running. I think the other important thing to say around CAMS is we have seen an increase in crisis in children having a mental health crisis. So you can see from the table it's quite small along the bottom, but we have seen an increase, even an increase from pre-COVID in terms of children requiring that support. So that's something that I know the CAMS team are looking at. Next slide, please. And so a little bit around our CAMS transformation. We have, again, digital is a bit of a theme here. We have been using some digital resources to ensure that we can reach out to children. Those have been really well received from children and from their families. We've also implemented more support into the kind of early intervention part of our service, to particularly focus on trying to catch people or kind of catch children before they get to that crisis point in terms of the early intervention piece. That's something that we want to focus more on. People may or may not know that the long-term plan details that a focus on a kind of 0 to 25 service for children who require mental health support is really important. So that's really where we want to focus our energies on, and not necessarily have a cutoff when people reach 18. We know that actually when you're 18 years old, that's a difficult time in your life without having any mental health challenges. So actually we're really keen to support having a pathway that extends up to 25 rather than having a cut-off at 18 where you move from a CAMS team and then all of a sudden you're in an adult team, and the kind of service does look very different. So I think that will be where our energy is placed over the next 12 months. Next slide, please. So finally, the last slide is on the Hillingdon Addiction Services, which I have to admit, because I'm 3 months in, is new to me. So what I've managed to pull together is some of the performance targets from the addiction service, which, as you can see, actually are very impressive. In some areas, they are better than the national average and are reaching their targets in most areas. But I won't talk more about the addiction services. I'm happy to take any questions. Thank you.
All right, good. It's we're back to where I can see everybody. Councillor Dennis.
Thank you, Chair, and thank you very much for that presentation. I've got a couple of questions in two different areas. Second set are going to be more around COVID, but first of all, at the beginning of the year, Hillingdon terminated our Section 75 agreement, which basically the council felt it was better to take social care back in-house. I mean, at the time, CN, my acronyms are terrible, but what's it, CNWL?
WL.
WL, yes. But, you know, we're very unhappy about that. They felt it came a bit out of the blue, and also they felt it impeded developing some of the sort of integrated services that really help improve these matters. Now, because we haven't really we've had meetings, but our initial sort of catch-up meetings were shelved because of COVID. We haven't been able to get back to that. So I just really wondered how that working relationship is now, and do you still feel that actually there might be gaps or there might be hampering of delivering the best possible service?
So thank you. That is a good question. So and helpful because I'm 3 months into my new job, so actually a fresh pair of eyes has been.
Sometimes when there's things like this happen, freshness is a very good thing.
It is,
so.
yes, and obviously I didn't actually live through that earlier on in the year. I think I think it's probably too early to tell. I think probably not having those meetings. I think we probably do still need to have those meetings to iron out some of the difficulties. It is always going to be difficult when you've got two different organisations trying to support maybe one individual, and I think that's probably fair in kind of for many organisations, and you have to iron out, so you have to have a working relationship, and you have to have a space which is safe to be able to iron out some of those difficulties that doesn't then impact on patient care. And I think it's probably fair to say that there have been times when that's still I think that is a challenge still. So I think what we probably need to do, and I know that I'm talking to various people from the local authority, because I'm trying to use myself as a bit of I call it an escalation point, but actually I don't want it to be about escalating things. I want it to be about resolving matters, and trying to understand who carries out what piece of work.
Thank you. I mean, I suppose from my perspective, I think that's something that's going to be of great interest to us, because obviously this is partly where we sit as a committee. And I suppose next time that you come and see us, which I think we have these every 6 months, don't we? More details on maybe how that is working and what you're doing would be much appreciated. I mean, I assume there are no massive red lights, otherwise you'd know about them at this moment in time, which is a good thing.
Yes, yeah.
But yeah, so next time, yes, so more details.
Absolutely.
About how that's working, maybe what sort of improvements can be made would be very appreciated. But as there's no red lights, that's a good thing anyway.
No, and I would hope that in 6 months I'd be telling you what improvements we've made.
Yeah, no, definitely, that sounds good. So Nikki will minute that, and we'll hold you to that.
No problem. I should be here in 6 months.
Great. And my second sort of set of questions was more sort of around COVID. I mean, the first part of it is, have you seen the change in sort of levels or type of demand? Because obviously there's lots of stuff in the media about sort of mental health impact. I'm thinking more about mental health, I suppose, on this of COVID. I mean, are you seeing a higher level of demand around need for mental health support?
So anecdotally, we are hearing that, yes. When I've looked at the data, we aren't necessarily seeing at the moment, apart from the children's services that I documented, and we're not seeing a huge amount of extra referrals coming through to any of our services. Now, I don't want to be quoted on anything, so all the things we're talking about is that because actually we haven't quite seen that impact happen yet. What we do know is that we are seeing high levels of acuity on our wards. So actually we think we have got quite a high proportion of people who are coming in sectioned rather than informal, so requesting for an admission. So I think probably at the moment our analysis would be, are people actually becoming more poorly and then requiring hospital, which is why in terms of our transformation piece, we're really trying to focus on that kind of front end. So how do we capture people who are sat at home worrying and maybe building up anxiety? How do we kind of reach those people? Because actually they end up having a bit of a kind of wall around them. So we're really relying on family members and friends to kind of notice that's happening to people. And that's why I want to focus on that front door. That kind of front door. If there was someone that people, somewhere or someone that people could speak to, they may reach out.
I mean, do you have relationships with housing associations as well? Because quite often, especially people who are very isolated, it's people who work in housing association areas where they work who might pick up on certain things. I've noticed that in the past anyway.
Yeah, so we do have relationships, but probably just only in relation to housing. So that's a really good point, that actually we could be reaching out to them to make sure that we can be a link in for support.
Because they'll people who work in those sort of areas might notice sort of unusual behaviour first of all, especially if the person themselves doesn't have too close relationships with families, which sadly can happen. Yeah. And my last sort of question, which is sort of around this point, which is just a personal curiosity of mine, is obviously COVID and all this sort of stuff, the suppression measures have changed a lot of our lives and how we work. I mean, hence we're doing this online at the moment, aren't we? Which is the meeting, which is good. It has its positives and its negatives. But I just wondered, I mean, do you think there's anything that you've learned about how you operate and provide support in the community by being forced to basically do things in different ways?
So I think it's really made us think about who needs, it has made us think about who needs a face-to-face assessment. Actually, when I started, we did a bit of work around actually how many people were still being seen face-to-face in our community mental health services, and actually it was still about 70 or 80% of people still being seen, which actually was quite surprising and different from the organisation I'd been to before, that I'd come from. So actually, I think it's made people really think about who does need to have a face-to-face assessment. Our kind of ethos has been, we really need to keep up with that. Our IAPT services have been very different. They predominantly saw people.
I think we've lost you, and you've frozen.
Oh,
No, you're back. You're back now.
You're back.
Sorry. No, that's okay.
Maybe my home Wi-Fi. I imagine half the house is on Wi-Fi behind me. So our IAP services are seeing people digitally, but again, I think it's making people think about that kind of risk assessment side of things. The other thing that has been difficult for staff having to use digital is, so for example, I'm sat at home now and speaking to you, but actually if I was working from home and speaking to someone who's in crisis, we've had some of our staff say, well, actually, I was sat in my daughter's bedroom working, and I was speaking to someone and they were very mentally distressed, and then that association with their daughter's bedroom becomes something, a time when they were speaking to someone in distress. So it's really important that we look after our staff as well, in thinking about using digital and making sure that we can create safe spaces for people to come and work.
Yes, thank you. I mean, that's a really good point. I mean, again, I suppose I'm setting you more homework in a sense. When you come back to us in 6 months, I think it'd be really interesting to see how all this sort of stuff plays out, because in a sense we're being forced to at the moment. But yeah, no, it's interesting. Sometimes forcing us to do things differently isn't such a bad thing. Anyway, that's everything from me. So, Chair, you can have the floor again.
Thank you, Vanessa. What you won't know is that some time ago, with the agreement of the other members, I divvied up the trusts between different members, and Councillor Dennis has responsibility for CNWL, and each of our teams and or individuals of councillors therefore get the opportunity to drill down in great detail and know that trust quite well. So that's why we get this excellence of questioning from Councillor Dennis on this occasion in regard to this trust. Councillor Arnold.
Thank you, Chairman, but Councillor Dennis's second question was actually going to be my question, so I'm fine, thank you.
And we often get that as well. One thing that is of interest is that some little while ago we did a very big piece on primary care, and produced a report about primary care and GP services. And one of the things that came out of that was the enormous amount of work that the Citizen Advice Bureau people do in terms of health-related issues, and the sort of tentacles in terms of different organisations who feed into them. And I just wondered if there was any connection or connect that you could utilise. You talked about schools and school nurses and CAMS. I sometimes think that there might be benefits in a bit more, and if there is already joined up, it's not that obvious, thinking in terms of schools and CAMS and citizens' advice, in as much as sometimes there's quite a lot of parallel work going on with different agencies, when coming together would be a lot more beneficial. And we certainly found that in our review, because we'd find people saying, well, we're doing this, and then citizens' advice say, well, actually, we've been doing this for quite some time, and we can find ever more greater experts. So just a bit of a thought around bringing those various people together in order to benefit the folks that you're dealing with, and therefore to signpost them much more accurately, possibly.
Absolutely, and I'm a huge advocate of working together, no matter what organisation people are from. And one of the joys of the role that I've chosen to come and work in, actually, is that it brings all of the services from Hillingdon, from CNWL all together, so that we can be thinking about that from a CNWL perspective. But I will absolutely reach out to Citizens Advice Bureau, and any other suggestions, because I'm new to Hillingdon. So any other suggestions are welcome.
All right, thank you. And maybe at another meeting, but not one of these, we'll have you back to talk in much more detail about the code, because I think that's a very interesting development. All right, thank you. Anybody else got anything else on this one? Can't see any hands going up. All right, thank you very much. That's very kind. Thank you, and thank you for your presentation, Vanessa. All right, Caroline, you're up for CCG. Nope. We can't hear you. There we go.
Sorry, the little icon kept flicking underneath my my microphone, so hopefully that's all right. So Nikki, hopefully you've got my slides to hand. Thank you. So I've just pulled out a few key areas to update members on this evening. So the first one was really kind of picking up on some of the conversations we've had around the COVID response, and just to sort of reiterate the fact that really through wave one, one of the key elements that we put in place in Hillingdon was quite a strongly collaborative system response. So we established what we called the COVID hub, which brought together on a daily basis our partners across the system. So partners from CNWL, Hillingdon Hospital, the local authority, third sector, and also sometimes broader partners, including the police, just so that we had that daily touch point in the system to take a check on what the issues of the day were, and how as a system we could respond and be flexible around things such as capacity, pathway criteria. Going forwards, we've also got Brunel University in our core membership, because particularly when we were looking at the sort of wave 2 type statistics, obviously with the universities being back, that was quite a key partner to be involved. So we, I think through that process, really started to consolidate some of our sort of more operational system relationships and ways of working. So in terms of wave 2, the 3 main priorities at the moment really are looking at how we refresh the support available for what is now called the clinically extremely vulnerable cohort, which doesn't really trip off the tongue, but was previously the shielded cohort, which I think hopefully members will be familiar with. And through wave 1, we worked with the local authority and with non-statutory services to really try and wrap some support around people who were being advised at that point actually not to leave their houses. Now some of that advice has softened, but we are aware that people will still be very anxious potentially about leaving their home environment, and that where we can, we should be sharing information about those people and making sure that we're getting support to them. And also coming back to Vanessa's point around mental health, just having the ability to check in on some people who might be feeling isolated or anxious in the community. So we're just looking at that at the moment for wave 2, particularly in the context of wave 2 being in winter, being darker and colder outside as well, and just sort of a less pleasant environment all around. We're expanding something we've called our escalated care clinics. So this was where primary care in wave 1 set up particular facilities to manage face-to-face consultations with people who had COVID symptoms. One of the really key things around COVID management is infection prevention control. So really trying to prevent transmission as much as you can. So where people do have symptoms of COVID, it's really important, first of all, to ascertain whether they really do need a face-to-face consultation. And if they do, that face-to-face consultation is done in a very safe way. So we established a site to deliver that care in the community. And what we've then subsequently rolled out is remote support. So again, members may be sort of familiar with some of the conversations that have been happening around things like pulse oximetry and being able to manage and monitor people's oxygen levels in their blood remotely, either through an app, which is sort of one way that we're trialing in Hillingdon, or literally by people being on the end of a phone and calling people people, and just checking what the kind of deterioration, or whether there is any deterioration in that oxygen saturation level, and how people are feeling, and therefore whether there should be a sort of a managed admission into hospital. And the evidence does seem to support that if people are detected early on in terms of that deterioration, and that the admission is managed, it does seem to have a better outcome. It's really early days. It's something that we are continuing to sort of test and monitor, but we are absolutely looking at how we do that sort of even further in wave 2. And then the third priority at the moment is really heavily focusing on the delivery of flu vaccine. Again, there's been quite a lot of information about this in the press, but it is really important this year to get as much of an uptake as we can to some of the vulnerable groups, and I'll come on to that a bit later in the presentation. We have focused on maintaining service delivery in primary care. So we know there was a big drop off in primary care activity during wave 1. However, practices did remain open in terms of they were delivering services. However, as I was talking about before with the infection prevention control measures, there were sort of different routes of access in. And one of the things that we have done is try to be really clear with messaging out to members of the public, but also to practice staff who might be having those conversations with members of the public about the fact that practices are open. However, there are different routes of access to clinician consultation now. So either through online portals or over the phone, ideally in the first instance. But then if someone really does need a face-to-face appointment, particularly in terms of things like childhood immunisations, which are really key, and delivery of smears, absolutely that's a face-to-face appointment. And we know that all of our practices are delivering those, and that following wave 1, we actually didn't have a backlog of childhood IMS, which was quite unusual across London, and that was the case across Northwest London too. And then lastly, I've just put a little bit there around infection prevention control measures. So we are trying to reduce the risk of crowded waiting rooms, particularly going into the sort of a season where people have a lot of respiratory disease traditionally anyway, and trying to focus on ideally having virtual consultations, but making sure that absolutely those face-to-face appointments are available, either where clinical or patient need determines. So just onto the next slide, please, Nikki. So winter planning, we are working with our partners, with the hospital, with CNWL, with the third sector and with primary care, on putting together a winter plan so that we support both the sort of seasonal pressures, but also any additional COVID pressures that we see across the system in Hillingdon. There are 3 areas to it. One is around step up care. So that's really looking at how we can try and deliver as much care as possible in a community setting before people's needs escalate to really needing hospital care. I've included the COVE in there, which Vanessa mentioned earlier in terms of the mental health element. We were also looking at putting in something called the Integrated Urgent Response. So that's being led by our primary care colleagues, and they are really at the moment assessing and where it's appropriate, redirecting patients away from sort of UTC and the emergency department and into our planned primary and community care services. So ensuring that we've got a really clear and smooth patient pathway back into either general practice or into an urgent response or rapid response type service, but trying to, as much as we can, stream people away from that front end to make sure that that is available for people who are in the greatest need. Hospital processes, that's a real focus on the same day emergency care pathways. There's been lots of good work done on that previously, but seeing if we can go further on that. Criteria-led discharge and 7-day-a-week discharge. So discharge is a real focus. Again, Vanessa mentioned this earlier. We are really working across the system to, as much as we can, have a very efficient flow and discharge support process to get people ideally into their home environment from hospital, and discharge to assess helps us do that, or if they need it, into another bedded environment, but really ideally not to have people in an acute setting for longer than they need to be, both because of the impact that has, we know that has on patient outcomes, and also for the pressures on the system. So that's the highlights of our current winter planning process. Next slide, please, Nikki. So this just comes back to the flu programme that I talked about. There are some really ambitious targets nationally around uptake nationally. So we've got 4 cohorts that have been defined as being sort of really the priority cohorts to focus on in the first instance. And I've just put some uptake figures in there at the moment. So that was at the 1st of November. There's a slight time lag on the data. But you can see, though, actually on the over 65s cohort, we're doing pretty well, and we're actually already above what our uptake rate for the full year last year was. There are relatively high refusal rates coming through this year. So we are working with partners to try and think about how we can get some messaging out to particular communities, particularly around myth busting. So we do know there are some quite unhelpful misinformation circulating on social media and through people's networks around what's in the vaccine, what impact the vaccine might have. So we're really doing our best, both at a North West London level and locally, to tap into any sort of community routes that we have to try and give people peace of mind and assurance that actually this is something that's really important for them to do for themselves and for their families. And just also to say the health and care workforce is a really sort of key priority group for this. So home care staff and domiciliary care staff can be vaccinated at their GP or by a community pharmacist. And again, we're working closely with our local authority colleagues to make sure that we're able to track the levels of uptake in our care staff. And we're doing that likewise in the primary care staff, and each of the providers will be doing that for their staff too. So next slide, please. And just in case you can hear it, there's fireworks going off outside. It sounds like there's a lot of banging, but that's, at least I hope it's fireworks. So North West London's CCG merger, I will just take you through sort of the highlights of that and give you an update as to where we are. So I think I've talked about this in previous meetings, but there's national policy to support the development of a single CCG per integrated care system. So an integrated care system in this context is North West London. All 8 CCGs have now voted to become a single CCG from April 2021. So there were a number of votes that took place in the same week in October, I think it was now. And that has been agreed. So the next stages of work really are to get that application in for governance approval, to really then develop what the new CCG constitution is going to be. And that will include what local oversight arrangements will be, including the establishment of borough committees, which will include representation from local authorities, probably the public health directors, Health Watch, and local GPs and lay members. So there will still be an element of local oversight and accountability. And then the other element of it is really around the ongoing development of our local integrated care partnership arrangements. So every area in North West London is looking at this. In Hillingdon, I would say we're slightly ahead of the game. We've got Hillingdon Health and Care Partners, which is our alliance of CNWL, Hillingdon Hospital, the Confederation, and H for All, which is our third sector alliance organisation. So we were able to slightly set the trend there and actually start to deliver in a way that is helpful for us and hopefully inform and shape what happens in North West London. So alongside that, there's been a management reorganisation, and just there are some names there in terms of people who will be coming into the borough to support. So there's a chief operating officer who will be supporting Brent Harrow in Hillingdon, and that's Sheikh Alaudin. He's currently the managing director at Brent CCG. We'll have a borough director, which will be a job share between Sue Jeffers and Richard Ellis, and they currently work for North West London in primary care, although Sue previously actually was the managing director in Hounslow, so she knows North West London very well, and also the way that the sort of borough management element. And then I'm really pleased to say that 2 of our sort of senior team members will be staying with us, Tavinder and Sean, who both are in our senior leadership team, so we've got some good stability there going forwards. And just, I think the next one's the last one. Yep, so just really quickly on the integration update, following on from that, I've just really set out what the key transformation programs for Hillingdon Health and Care Partners are. So really building on our primary care and our neighbourhood development locally, so wrapping our services from a community, both physical and mental health perspective, and primary care around our what we call neighbourhoods, of which we have 6 in Hillingdon. Urgent and emergency care, which at the moment is very much focusing on those winter plans, which I outlined earlier on in the deck. Planned care or elective care, which is really looking at how we join up the pathways between primary care, community care, and secondary care to make sure that where people do have planned procedures or need planned care support, that happens in the right setting and it happens as effectively and efficiently as it possibly can. children's and young people services, and Vanessa talked a little bit about some of the transformation around those as to how we might be able to integrate some of our services and also extend some of the age limits. So traditionally, we've been looking at sort of 18-year-old cutoffs, but actually for some groups that might be up to kind of 25, and seeing where we can be flexible around that to support our young people. And mental health, LD and autism and transformation programs around that, particularly around making sure that we integrate some of our primary care services with our community care specialist services. So that really is a summary from me, but happy obviously to take any questions.
Right, Councillor Radia and then Councillor Mathers.
Thank you, Chairman. Caroline, I'm wondering if the CCG is doing any sort of contingency planning, if it is tasked with the distribution of any future COVID-19 vaccine. And my other question is about cancer screening. I know that nationally, in the early part of the lockdown, we saw a dip in the cancer screening rates. And I'm wondering if specifically in Hillingdon that has now recovered.
So in terms of the COVID vaccination, there are definitely discussions happening at the moment. We are slightly limited as to what we can say at the moment because there's lots of embargoes around levels of information that is accessible. But I think what I can say is that at a North West London level, we do have a programme in place thinking about how sort of logistically we would deliver that sort of sites, workforce. And so that absolutely is something that there's a lot of thinking happening about at the moment, as and when that might be relevant. In terms of cancer screening, so unfortunately, one of the issues that we have is the data that we tend to see is a little bit out of date. So the last data that we had, which was really for quarter one of the first year, had a bit of a lag on it. So it's a bit difficult to update at this point, but what I can say is in terms of cervical screening, for example, we're actually ahead of trajectory in terms of the recovery. So that's the delivery of samples to laboratories. So we've been tracking that activity from a cervical perspective. From a breast perspective, I will double check with the public health teams and I'll come back to you on that. I don't have that off the top of my head, or the latest data for that off the top of my head, but I can get that to you via Nikki if that's helpful.
All right, thank you. Councillor Mathers.
Thank you, Chair. I have two questions, and I'm still learning quite a lot being on this committee as a newer member, but so do please pass the question to whomever, and Chair, please also correct me if I'm off the mark. But on this occasion, when I'm off the mark on other occasions, maybe not. But the first one is within the materials we've got, it speaks about significant pressure on the whole system in North West London, particularly providing care for ageing population and increasing demand with fewer resources. I just wondered what impact COVID had on that. Not that the pressure has disappeared, but whether it's had a kind of net gain or net loss in terms of budget pressures, because maybe some services haven't been able to operate in some way or been postponed because of COVID in wave one, or that just the acute aspect of it has meant that costs have just spiraled. My second question is a little more specific. You mentioned hospital processes and looking at the criteria-led discharge. I'm increasingly aware over recent months that particularly with elderly patients, their discharge has, where they have a care in place or need a care packet in place, has been misaligned with their needs. So for example, these are very specific, but just a broader point around how we're discharging elderly patients where there's a care requirement of a relative or a carer. So for example, elderly people with dementia being charged with a bag of medicine and kind of dropped home by transport and left with this big bag of medicine, when actually they need support with that from family members, or others being discharged without fully knowing what the next steps are, explained to them and described to them. So it's just a kind of that relationship between hospital discharges and dissemination of information to carers and relatives, as well as those, particularly for the elderly, but anybody who requires that sort of support, rather than just looking at the balance of getting people out in time. Where are the checks and balances within that? Thank you.
Thanks. So in terms of the financial element, I can certainly talk about that from a sort of CCG perspective. Other colleagues from the providers might be able to sort of lend their perspective too. So one of the things that happened when we went into wave one, we went into what we called level 4 emergency measures, and that in essence meant that we had a completely different financial framework to what we would usually be working on. So usually what happens is we set a budget at the start of the year, and we work through that in terms of delivering a level of sort of cost efficiency to come back to a break-even point and sort of balance our budgets. What happened this year was, in essence, we were brought back to break even each month. So there was a national control basically taken of the commissioning budgets. So what happened was, on a month by month basis, we submitted a spend summary, and that was sort of given back to us by NHS England. They did scrutinise it, so there was a level of challenge in there to make sure that what we were spending was appropriate. But ultimately, that did mean that we are at a sort of coming out of month 6, we were at a break-even position in the system, which and previously in Hillingdon as a CCG, we have managed to either break even or deliver a small surplus, apart from 1 year in my memory. So from that perspective, it's probably aligned to where financially we would have been, but we've just had less agency really over how we've been able to plan. So it's a bit different for the second half of the year. We've basically been given a budget now, which has gone through North West London, and North West London have worked with us as commissioners and providers to set those budgets. So obviously we're all being tasked as a system to come in on break even. And so each organisation is working to that. I think for the CCG, that means at last look, we had, I think, an efficiency target of around 2 million to deliver at the back end of the year, which we think is doable. So it does seem, from a resource perspective, I'm not party to how the sort of budget setting on a national level was set, but if they've given us the resources they think that we should have, we seem to be living within our means this year around it. That being said, they've probably been prioritised slightly differently and been driven by certain slightly different factors because of COVID. But from that perspective, from a commissioning side anyway, we seem to be on track. I don't know whether at that point any of the providers have a view on the finances.
I mean, maybe just to add, Chair, just following on from Caroline, I think for this year, the financial regime has been slightly unusual, but I think we all are sort of very aware that what was initially sort of seen as a sort of financial support package for the beginning of the year seems to be rolling out across the rest of the year, but sort of taking into consideration potentially how COVID will evolve and potential vaccines over the next few months. I think that the financial regime, certainly, we couldn't certainly, I'd have thought, expect more to be back to normal from April onwards next year. Just on your second point, I think absolutely the piece around discharges for care of the elderly is if you look at all the parties involved and particularly sort of communications around families, it is a huge logistical sort of exercise to be done. I think my reading of sort of the consistent feedback I've had from patients and families from the hospital side is that I think we've got much to be proud of, but there are certainly particular elements that we can all work together as a system to improve, because there are some key things that absolutely around if somebody's vulnerable or frail, that we really make sure that we're all joined up to make sure that discharge is planned appropriately.
All right, thank you. Sorry, Caroline, do you want to come in on that last bit?
No, I was just going to echo what Jason said, really, around making sure that communication is joined up. And one of the things that we are looking to do is really focus on the planning of the discharge. So I think a lot of the time at the moment, some of that is right, and I think we're going in the right direction. But as Jason says, we've still got room to improve on that. And I think for us, it's consistency. getting that right across 7 days of the week. It shouldn't matter whether someone goes home on a Saturday, a Sunday, a Monday, Tuesday, Wednesday, and ensuring that all of the services and the planning and communication happens effectively regardless of that. So that really is a priority for us.
The problem probably is that more often we would hear about the negatives. And tell us things about stuff that's got about things that have gone wrong, and there will be things that will go wrong. I mean, we understand that, but it's good. I think that it's more than good. It's excellent that that's being focused on, because it's clearly something that you know about, and it's something that has the capacity to go wrong, and when it does, it's a big thing. So that's great that that's being kept hold of. Very quickly, there was just one general question that I had in terms of, and it kind of crosses between Caroline and Vanessa, I guess, and maybe even Jason as well, as far as the hospital is concerned. But is this whole business about mental health? So before the COVID, you would have a cohort of people who you knew about suffering from mental health or coming in and out of mental health issues, and in a sense they would have got used to what to do, where to go, and who to contact. We've now got a whole new cohort of people who are experiencing things that they haven't experienced before, and whilst it's not perhaps helpful to over emphasize that because people are in a certain state or in certain states, maybe it's mental health as opposed to very specific to where we are, that there's still the need to at least allow them to for them to know where to access services and so forth. So the extent to which we're able to deal with the kind of COVID cohort who may not be as knowledgeable as the pre-COVID cohort in terms of mental health. And it may just be messages, and it may just be information. So if you are feeling anxious and worried and lonely and all the rest of it, which you might have felt before anyway and never classed it as mental health, and suddenly people are saying, well, maybe it's mental health, which also has an impact on people. But just so that more people have a better understanding about access to services, which kind of goes back to what I was saying to Vanessa about citizen advice and joined up thinking. I don't know if you have a quick view on that.
Yeah, so I mean, it is something that we're conscious of, and we have actually put a bit of a comms campaign together locally in Hillingdon. So we've put some more information up in some of the bus shelters, and there are some up in the sort of local notice boards in some of the borough areas about access to IAPT. So it's not described as IAPT, obviously on the poster. It's sort of described as, do you want to talk to someone? Are you feeling a bit low? So we are trying to get some more information out there, and we're also putting that out through our sort of social media channels, really to encourage people who might be walking, going for a walk in the park, walk past the notice board, see it and think, actually, it would be good to have someone to talk to. I think we're conscious of that kind of low level anxiety which could escalate into something if people don't pick up the phone and speak to someone. I think the other bit we probably need to have a bit more of a think about, again, particularly going into winter, is how we also tie in with some of the non-statutory organisations that might be able to help with that, because IAP services are fantastic and have really good outcomes, but there is something about sort of the kind of broader community resilience and how we can support that and make sure that is at a kind of decent baseline level in the system.
All right, thank you. It's probably a sort of ongoing and increasing piece of work. All right, I'm very grateful to you for.
Sorry, can I ask one question?
Yeah, sorry, I didn't see you. We can't see you as a picture rather than just your picture, as it were.
Yeah, sorry. It's only because my internet's unstable, and if the
I see.
is
Okay.
on, I lose
yeah,
you guys.
of course.
Really sorry.
This is
Caroline,
it's a verbal equivalent of raising your hand. That's fine.
Thank you. Caroline, you when you spoke about the flu vaccine, the flu vaccines or the flu shots that are being given out. It's worrying me, largely because one of the big worries that I have is misinformation in regards to the COVID vaccine as well.
Yeah.
so you showed a 5% rejection or refusal rate, I think, on average, but I didn't see the difference. I might have missed it, but the difference between last year and this year, is that a particular spike? I know sort of anti-vaxxerness and anxiety around vaccines and misinformation aren't a new thing. They haven't come around because of COVID, but is that a massive spike on last year? And also the other question is, should we and are we putting groundwork as much as we are with information campaigns for the flu vaccine? Should we already be getting ahead of a COVID vaccine, whether that's the Pfizer one, the AstraZeneca one? Eventually, we hope to have one. So, do we lay the groundwork to make sure that we can counter that as well? You won't have all the answers to this because if you did, you'd probably be running NHS England. But I wonder if we're already putting some work in place already on that.
Yeah, so absolutely. I mean, just on your first point around the refusal rate, usually it's sort of between 2 to 3%. So 5% is quite high, and I suppose there might be a couple of reasons for that. So the other reason might be that we're probably being slightly more assertive this year than we maybe have before. So we are really proactively ringing people. So maybe in previous years, people wouldn't have been listed as a refusal, they just wouldn't have responded, and whereas now we are following up and trying to make sure that we are logging where people are refusing, that's coming through. But I think the element that I didn't put in the slides there, I think the really key element is particularly around inequalities, and just the difference in those refusal rates and actually just uptake rates overall between some of our areas of sort of lowest and greatest deprivation. And we can see that even relatively early on, there was a kind of a 3% difference between the most deprived and the least deprived areas, and that was across Northwest London. So when you narrow that down, that becomes even greater. So absolutely, it's something we're focusing on for flu in terms of the messaging and the myth busting, and absolutely equally, therefore, it needs to be something even more so with the COVID vaccine when we look at the impact of COVID on inequalities, to make sure that we are getting ahead of the game. And yeah, I don't know what's in the heads of the people in NHS England, but certainly in London, we are already having those conversations around what are the lessons learned from the flu campaign and the comms around that, that we can take forward, and how can we really be kind of smart about engaging with communities and engaging with people on the ground to get those messages across.
And that was most. So you said most deprived and least deprived. Most deprived, I assume, maybe wrongly, was a higher refusal.
It doesn't show as refusal at the moment. It just shows as lower uptake.
Lower uptake. Okay.
Yeah.
All right. And is there any way of? It's very tough. I wonder if there's any way for us to record trends in comments people are making as to why they're either not uptaking or refusing, and therefore whether we can, dependent on what they're saying, we can tug on different partners, stakeholders to counter that. So the big one that comes into my mind always with this kind of community information campaigns is mosques, churches, synagogues. That, if there are trends in why people aren't uptaking or refusing, then we can help, the council can help. These are all things so I'm sorry if I'm repeating them, but I wonder where we can help with that, because I'm really worried about the uptake because if the flu vaccine is getting this, then I can only imagine the COVID vaccine will be even worse, and it's critical. Uptake is critical to eventual community immunity. So I don't know if you have a method of recording why people aren't uptaking or refusing.
It's really difficult because it comes down to how the information's coded to get it at scale. We are recording it when we are getting it anecdotally or seeing it on social media, but it's not a precise science. It gives us some insight, but it doesn't give us the kind of the level of population data that we like in health. But it does give us that insight into in particular areas or particular myths that we can counter. And I think we have absolutely, and thank you for the offer sort of in terms of the council, absolutely all of the routes that councillors know through into their local communities will be really important for the COVID vaccine. And equally, I think there's something we can probably do across London to share, because I think, you know, London, although we're slightly on the outskirts, a lot of the community groups within London do sort of have similar characteristics. There's sort of family members and groups that are in different areas. So if we can really mobilise some of those communications pathways across London, I think we've also got a way in there too.
Most of the religious communities and individual communities around individual places of worship will have newsletters or magazines, and I'm just thinking that campaigns across the board, as far as those magazines and newsletters are concerned, might be interesting, because you already have a kind of place for discourse about all sorts of things within those magazines, and comments will be made there about whatever it is, usually about how best to cook something or how best to make something, and a you know, generational difference of opinion about buns and things. But on a serious note, if we could tap into those magazines and have a sort of medical view of the take up of vaccine, both for flu and for COVID, that would be quite that would reach out to a lot of people, because those magazines go to hundreds of people who are members of those places of worship, not whether they go or not, but they get them anyway, and they'll often read them and use them as methods of contact. So it might be quite a good route to get into, and certainly it's something that we as councillors can connect with our various places of worship and see if they will take, you know, an article from one of us or from you or from anybody about this, about the wisdom of taking up the immunisation. All right. Okay. I don't know why we're getting feedback. We'll be getting feedback at somebody's. Right. Any more questions for Caroline on this one? No. Okay. Right, Jason, you're up.
Thank you, Chair. Conscious of time, so I think I've got about 70 slides to go through, if Nikki didn't mind. So apologies, I haven't done any slides, so if it's okay with everybody, it's just
you can take us through to midnight, don't worry, you're okay.
So from a Hillingdon Hospital's perspective, sort of the overview piece is we've got an agenda sort of focused on two key parts. There's the sort of core business of running our hospitals, and then there's the rebuilding of the Hillingdon Hospital. If we just start with the core business of running our hospitals, just picking up on sort of the previous discussions, it is very much, if you look about this year, how we've all come together working as a system, both across primary, community, social care, and the acutes. And I think, picking up on the Harefield piece earlier, the providers in northwest London have sort of had a marked change actually this year about how we network our services together, particularly around critical care. And then Boyd from London Ambulance Service as well, thank you, of actually on a number of things where probably we weren't also well joined up in sort of previous years, particularly with the London Ambulance Service now, about how we're sort of working and sharing when we're going through pressures. So a very sort of pressured year, again, slight uncertainty about what people refer to as the second wave with the sort of current lockdown. I think if we look previously, if we go back sort of a month or so, the sort of numbers of people in our hospitals who were COVID positive was probably in the teens, so probably anyway sort of 15, 18. The last sort of week or so, more between sort of 30 and 35. So not anywhere near sort of where we were sort of in wave one, but there has been a noticeable increase. And then the key piece for us then around that is to make sure that we have our sort of critical care capacity, our medical sort of high dependency capacity, and then we sort of, as people have learned through the pandemic, really making sure that we almost sort of segregate what people refer to in many different ways about blue or red or green or all of these things, but in effect, COVID wards and non-COVID wards. There's a key piece for us. So for all of you, when you've come to the Hillingdon site around our emergency department and the sort of urgent care centre at the front of the hospital, it is one of those pieces that it's over sort of the history of the last sort of few years, it's turned into a bit of a rabbit warren. And what we are doing work will sort of commence shortly, is look to do some infrastructure works at the front end to make sure that we've sort of got a very clean sort of physical layout between what we sort of refer to as a COVID pathway and what is the sort of non-COVID pathway, and that work will be starting shortly. The other key piece that I think where we've discussed previously, the sort of main regulator of quality for for care providers is the Care Quality Commission. We had an unannounced inspection by them on the 4th and 5th of August 2020, and on the back of that we have been working sort of relentlessly on a number of issues, but particularly around infection prevention and control, to make sure we put the changes in place that absolutely are required, and we've been making broadly good progress on that. On the 29th and 30th of September, we had a follow-up visit by the Care Quality Commission, and on this occasion they came also with the Health and Safety Executive. This is probably the first time the Health and Safety Executive and the Care Quality Commission have done an inspection jointly. I think both sides found it quite a beneficial learning experience, in that if you look at the CQC, they very much have a lens of seeing services from a patient perspective. Health and Safety Executive probably have a more so lens that they see how services are provided from a staff perspective. The key piece that sort of has come out, and we've had subsequent discussions with the Care Quality Commission and the Health and Safety Executive, is certainly around staff changing facilities. So in our emergency department, around just making sure that we have really fit for purpose changing facilities. So just in reference to the part previously where we're doing infrastructure works on the COVID and non-COVID pathways at the front, we're now incorporating in that work that we're going to be putting in new changing facilities in the emergency department. The other one that we learned from when we were sort of discussing how we're dealing with sort of all issues around COVID is there are masks which are sort of reusable, so more so the masks with the filters in them. The piece that we've had in previously has been around the responsibility of the individual as to make sure that their filter and their masks are checked monthly, and anything that needs to be done around valves and such like. The one we've agreed with the Health and Safety Executive and the CQC around that is very much to put also to complement that a sort of systematic approach that the organisation tests those masks and make sure that they're tested as well. So number of pieces of work around sort of driving services forward with the Health and Safety Executive and the Care Quality Commission, and that work is continuing at a pace and will continue certainly over the next 6 months. As part of that, we are in working as a system and being supported with that. But the other one, as we've previously touched on, is we're working quite closely with Chelsea and Westminster hospitals, so the Chelsea and Westminster and the West Middlesex. So in terms of certainly some of our improvements around infection prevention and control, some of the the expertise they have around their nursing leadership, and we have the Chief Executive of Chelsea and Westminster, who is also the Chief Executive of the Integrated Care System, Leslie Watts working very closely and supporting us as well. So big improvement drive going on across the board, but we are both supported from Chelsea and Westminster colleagues, working very closely with Hillingdon Health and Care Partners as well. Again, if just touching on how Caroline presented it, there's a key thing as we move forward, certainly over the next few months, around how we work as a system in making sure we sort of are delivering what patients require. So they are almost the key sort of headlines around the sort of core business of running hospitals. The other element then is the new hospital. We have presented in October to what is called the Joint Investment Committee of the Department of Health and Social Care and NHS England and Improvement, so the two main regulators on that side for the NHS. The strategic outline case for the new Hillingdon Hospital was agreed with all these things, with conditions, but the conditions were expected to have in place, and they very much relate to the detail required in the outline business case. So in how the NHS works, it's a three-stage business case process. There's a strategic outline case, the outline business case, and then the full business case. So strategic outline case, tick. We're now working at pace to have the outline business case. We are in discussion with the Department of Health and Social Care and NHS EI, but we are looking to have that case with them by summer next year. With that, then you would then envisage the full business case would be ready sort of summer 2022, and we would actually start constructions work then sort of mid-end of 2022. So a huge amount of progress. Thank you again to sort of colleagues across the system for the amount of support, and also almost with that the joint work. So as we look at the models of care, if we look at how we want to best provide services for patients, a number of pieces have been taken forward as part of the outline business case process. If I pause there, Chair, and if there were any questions.
Councillor Arnold.
Thank you, Chairman. I wonder if you could, I know that over the years there's been some management problems at Hillingdon Hospital, and I believe that you've now appointed some people and that's sort of stabilising a bit. Could you just talk a bit about where we're at the moment in terms of senior management?
Yeah, no, so absolutely. So apologies, I had written that down on my piece of paper, so sorry, I was not mentioning. So in terms of how the NHS Foundation Trust or NHS Trust are structured, the sort of key pieces for executive leadership on a trust board are a chief executive, a chief nurse, a medical director, and a finance director, and then you have various other directors. If we go back through that order, our finance director post has been vacant for a number of months, and we've had that position covered in the interim by somebody who's just come in on a sort of interim basis. That post is now out for substantive advertisement. So we're in the process at the moment of recruiting a substantive finance director. The chief nurse position, so Camilla Wiley, who's currently the chief nurse, is leaving in January. What we have agreed with Chelsea and Westminster is Pippa, who is the chief nurse for Chelsea and Westminster, and she's also the lead for quality for the North West London Integrated Care System, will be the chief nurse at Hillingdon Hospitals. We have also appointed a director of nursing from Chelsea and Westminster, who will be full-time on site at Hillingdon Hospitals. And so with that, we'll very much have a more strengthened sort of 5-day-a-week support, but also then Pippa overseeing that, and Pippa will sit on the board. The medical director post, so Dr. Kathy Kale left last month. and now Dr. Kubi Aida has started. She is a gynecologist. She's been an associate medical director at Chelsea and Westminster, and is sort of coming in very sort of, really got good ideas and started to drive forward a number of agendas already, and has only been with us sort of 2-3 weeks. The other one that is not sort of a statutory position on trust boards, the sort of people and OD director. So Sue is currently our director of people and OD. The post at Chelsea and Westminster has recently become vacant, and what has been agreed on that is Sue will cover both posts for the next 12 months. So Sue's covering both of those. For the chief exec position, I have been sort of wearing that hat as well for the last couple of months. Patricia Wright is coming in as interim chief executive, sort of right at the end of November that week, beginning of December. But I think I can say it as well, was interviewed last week and has been appointed substantively to the post. And then what we will be looking to do going forward, just because of the sheer sort of size of the agenda going forward, Patricia will be very much focusing on that sort of day-to-day business of running the hospitals. And I will sort of be focusing on the rebuild at Hillingdon Hospital, and then reporting into sort of the chairman and Leslie Watts as the system lead on that.
Thank you for that. My next question, slightly different, is usually during these meetings we talk about A&E figures. And nearly every time someone's come in, they said they're not as good as they should be, but by the next time we come in, we'll have vast improvements. How are those figures looking now? Obviously, I appreciate it's a slightly different time.
So I wish I could say something different actually on that one. I think relatively, so that if you look at the urgent and emergency care target around 4 hours, the piece when it originally came out in the NHS Constitution was 95% of people should be seen within 4 hours. I think from our perspective at the moment, we are sort of currently in the low 80%. The issues around that is sort of making sure sort of predominantly we've got flow through the hospital. So if you look at how fast the emergency department and the urgent care centre sort of turn, is make sure that we've then got the flow through the assessment centres, the beds and the discharge to make sure that we deliver it. Our performance is relatively, if you look at the London League tables, sort of mid-table, but that's not, to answer your question directly, an excuse. There is absolute sort of focus on that needs to be probably the trajectory we're setting should be about 10% better. And that's what we will envisage, which we're working with the clinicians with at the moment. You get that clinical ownership and we deliver that by the end of the financial year.
It's interesting you talked about flow, because I think last time we met, there was a piece of work that were being done on flow within the hospital that we were told would significantly improve the A&E figures. Has that finished? Has that started? Where are we?
So yeah, so if I'm completely candid and honest with you, I think the flow piece of us working at the system, and I know Vanessa's there 3 months in, I mean, she's really starting to grab hold of some of these pieces with colleagues across the system, and we are really sort of working to make sure that we work it through. I think the piece around certainly the last month's performance where we haven't had the expected improvements that we should have had, that mainly was related to an episode of diarrhea and vomiting on our sort of medical assessment unit, and we lost capacity probably for about 5-6 days, and that did impact flow through the hospital.
Chairman, thank you.
Thank you. Jason, you know that in the meetings that we've had and the interactions that you've had with this committee, we value you very highly, and this is not directed at you. But I have to say that as far as the committee is concerned, and I'm pretty sure I can speak for everybody, it is incredibly, in the vernacular, disappointing, and that pitches it very low, that senior staff, at a time when we need a team that is forward thinking and hugely behind the hospital build and has a vision in regard to that, that we are still swapping and changing senior managers. It's just unbelievable that we don't have the sort of people in post, apart from yourself, who are going to stay with us for a long time and are going to head up the whole drive of the new hospital. And I don't understand that our newly appointed chief executive has a history of heading up new hospital builds, and we seem to be relying on this very important support relationship with Chelsea and Westminster, which is great, but we want a Hillingdon hospital, and we want a management team that is the Hillingdon hospital and is capable of running it forward. You've just told us about a number of people from Chelsea and Westminster who are going to essentially have 2 or 3 jobs helping to oversee parts of what we do. I really don't understand why the system, and I don't doubt it's people, you know what I mean when I say above you, but beyond you, or in the main part of the system, that look at Hillingdon Hospital and think that this is acceptable. I really don't. And I would hope that you would, however you can, pass that on to those decision makers, because it's bad enough that it should happen anyway. It's worse that it should happen now, when we're running into a time when this new hospital is being thought about, built. I mean, at one stage it was talked about as being like for like, but just a bit newer. That isn't good enough. It really isn't. We want to see much more creative thinking, because the residents of this borough and the wider patient community have a real opportunity for this new build. And I do understand the financial timetable and all the rest of it, but nevertheless, what we don't want to be doing is seeing something built and then somebody says, well, actually, what we really ought to have done is X, Y, and Z, you know, joined up thinking with this, that, the other. But this merry-go-round of senior officials who don't seem to stay terribly long, or are interim, and then something else happens. I suppose in a sense it shows a lack of grip. And you know, you've been the constant, which we're very grateful for, and you've been the flag waver, which we're very grateful for. But if in any way you can pass on our significant concern, it's very difficult for us to be trusting in management teams that switch around so often, and with so little experience of what's coming up. And it's a real worry, and whether it's too late to do anything about it now, I don't know. But I just thought we needed to put that to you, because I just don't think it's good enough, and I think we're being treated in terms of hospital management like idiots, frankly. So if you can pass the extent of our concerns on, I'd be very grateful. I see all nodding heads going on, so that's all. I don't normally kick off, but I think it's just something that it's been a frustration building in us for a long time, and to have it at this time when we're hoping to get something really significant going is a massive disappointment. All right, great. Anybody else got any other questions for?
Yeah.
Jason.
Sorry, I had a quick question, and just to reiterate everything you just said.
Councillor Manali.
Jason, on the A&E numbers, you said you'd missed them again, or you were underneath where you wanted to be. I don't quite understand how that's possible. Given that from everything I understand from friends at A&E doctors, albeit not in Hillingdon, numbers in A&Es are massively down. In fact, I was texting friends who were doctors who were saying that they were sat around not doing much and really anxious that people weren't coming into A&E for reasons that they should have been. How is it even possible that we missed the targets?
So if you could give me any mobile numbers you can give me, that'd be fabulous. If there's people out there,
mate, get them in an Uber to Hillingdon Hospital.
Yeah. So I would say it is multifactored, but one of the key issues is staffing. But I think that is something that's being worked through. Absolutely, you're correct. Factually, the numbers are significantly down if we look on previous years. The piece, just referring back to the work we're doing on the infrastructure at the front, is staffing and the logistics around the rabbit warren we have at the moment makes us sort of very suboptimal. So doing the estate works where we have a sort of dedicated COVID and non-COVID pathway that's very simply physically to go through will absolutely help efficiency. And I think on the other pieces so there was a sort of a context. We have had sort of month on month throughout the summer improved performance. But yeah, if I was to answer you directly, the two key issues which affected the previous month's performance were, one, the issue around diarrhea and vomiting, which affected our medical assessment unit for just under a week, which affected flow. And the other piece was we had a IT issue in one of our sort of big servers, which took down much of our sort of diagnostic capacity over a weekend, which again, just in terms of a month's figures, having poor figures on a Saturday and Sunday did materially affect our position.
Yeah, I mean, I guess it all goes back to Councillor Riley, Chairman's central sort of point earlier, in that with a lot of these things, we have been hearing the same stuff, and it's not your fault, Jason's, at all. I'm not having a go at you. It's more of a management problem, in that I remember me and Simon 2 years ago asked for a HR staffing strategy after the new A&E went in. We sit next to each other when we're physically there, and I still haven't seen that. And so the frustration from us comes from hearing the same things over and over again. And I guess the only way that's fixed is some coherency and consistency in management, like Councillor Riley said. But I won't repeat, because Councillor Riley put it simply. I won't repeat that. But thank you. Thanks for taking
and maybe just to add on that, I think, again, probably just a personal thanks for all of you for persevering with us. I think the key element is, if you look at the historical piece on the running of Hillingdon Hospital, which I've sort of done a piece of work on, there unfortunately has been a sort of 2-3 year cycle of wholesale change. So just when you've had a team in there that potentially you can start thinking of, yeah, these are the key issues which they're sort of now really sort of getting familiar with, and works sort of being taken forward. You have probably over certainly the last decade had that cycle on a 2 year, 3 year sort of phase, which I think is, I share your frustration, because from a basic rules of hospital management, for what is required in some of the sort of long-term improvements, you do need a stable leadership team for about 5 years.
Well, as we said before, Jason, we're very grateful to you, and if you do have the channels at your in your management to pass these comments or these feelings and concerns upwards, that's where it needs to go, and we'll do our bit from our end to also shake up some of the senior end as well, because it has to be done, and we can't have this happening at a time, as I say, when the concentration on the new build. I mean, what you've just said about earlier on about spending money on various aspects of the A&E department. I mean, some people will say, well, hang on, why is that money being spent when literally it's going to be torn down in 3 years? but I understand that there are pockets of money that can be spent that have nothing to do with the hospital build, and at least for that period of time, the sort of quality that the CQC and the Health and Safety Executive were pointing out to can be rectified. So at least it's something but what people don't need to worry about is that money is being spent that ought to go or should be attributable to the new hospital or anything else, because this is very ring-fenced money for a very specific event. All right. Thank you so much for that. So now I'm going to turn to Dan West at Hillingdon Health Watch, just to give us a very brief view from your organisation, or roundup, or idea about how you see things from your perspective, if he's still there.
Thank you very much, Chair. I am.
Oh, there you are. Yes.
I am. So yeah, just a very quick roundup. We moved to remote working just prior to the March lockdown. We've been working remotely since then, so we haven't been in the shop in the pavilions. We've been able to offer all of our usual core services by phone, social media, and through our website and by email. Rather than sort of just go on about the nitty gritty of what we've been doing, some of the feedback we've had, a lot of it is geared around mental health. We did run a few surveys right back at the beginning of the first wave, and mental health, concern about isolation was obviously one of the key themes. We've been very lucky to be included as part of the HHCP COVID hub, which means that we've had really good view of what's been going on. So any concerns that we've had from the public, we've been able to sort of address them appropriately. We've had, of late, we've had quite a few concerns about people going into hospital, because, you know, the safety of the hospital itself and primary care. We did share, I think it was in July, the business as usual or open for business campaign that the NHS had. So that's obviously been one of the points that we've been pushing. And generally speaking, our drive for the last, 6 months now has been advice and guidance, really. That's what we've been aimed at. All of our usual core functions have been carrying on. So our Young Health Watch has been carrying on, work with CNWL, with CAMS and the transitions as well. So that hasn't actually been slowed down at all. We were actually able to hold a Health Fest event again this year. Obviously, it was entirely online. We didn't have a huge turnout, but those that did attend did find it very useful. And again, a lot of that was geared towards mental health. So that was really, really key. But yeah, once again, you know, I'd like to thank Caroline for our inclusion in the HHCP COVID hub, because it has been incredibly important for us to know what's been going on the ground. And that's definitely informed a lot of the work that we've been done, and just trying to disseminate some of the key messages out into our, you know, through our channels on social media and our website has been huge, because we've seen obviously a massive uptick in reach through social media. It's been a huge sort of boost for us over the last 6 months as well. Thank you.
All right, that's great. Thank you very much, and that's a very good roundup. I think in terms of both Caroline and Vanessa, many of us will have various ideas about communication routes and so forth, and we'll get those to you outside the committee, because as I say, very often we'll do pieces of work that throw these things up, and I'm not sure that we necessarily pass them on quite as much as we ought to, because we just assume somehow that they will happen. So, and you know, I wave my magic wand and suddenly it all becomes lovely. All right, look, we'll finish there. Thank you so much for everybody. Nick, Boyd, Vanessa, Caroline, Jason, and Dan. As ever, these sessions are absolutely amazing for us, and we find out so much. And I know they do go on a little bit, but we've actually done quite well tonight in terms of timing. But we're very grateful to you all, and we'll go on. Good grief, Councillor Dillon has appeared in a small box on the bottom. It's like Celebrity
I've been
Square.
listening intently since 7:15.
Good man, well done. I could see that you were, and another brilliant beard. Well done. So with that, I'll close this element of the meeting, and we will have a look at our work plan. Thank you very much, everybody. See you soon. Bye 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 bye. What?
Right, so we've moved on to agenda item 6, which is the committee's work programme. As it stands at the moment, we've got our next meeting scheduled for the 12th of January. And as agreed at the last meeting, we will be looking at the Great Western Line. I think I've put in the work programme the issues relating to British Transport Police, Network Rail and Crossrail. I've reached out to colleagues and gained some contacts and have been in contact with a number of people already. So I'm frantically trying to secure witnesses for that meeting. At the last meeting, members also requested that we have an update from post offices at some point in the future. What I've done is I've actually contacted the 2 gentlemen that attended our meeting in January this year and asked if it would be possible for them to attend the meeting on the 9th of February to provide members with an update at that meeting. It's only recently that I've contacted them, so I've not yet heard back from them, and I will update you when I have heard back from them, because I don't know if you remember, but last time it was quite difficult to get them to attend at short notice, and by short notice I mean it was about 6 months. So there's not really much else to talk about on the work programme, other than, I don't know if members recall, but previously they had asked if it'd be possible to have a specific meeting to talk to THH about all of the issues there, because these meetings aren't really long enough for us to go into any great detail about the issues that they're facing.
Well, why don't we use, why don't we use, I see the 9th of February, we've got post offices ? It's close enough to the, because Jason only really touched on, and I hope you don't think I went too far with Jason, but I was so blooming angry about
I didn't think you went far enough, John.
Yeah, I don't think I went far enough.
As you said, you were actually, you were strong. You actually, we could have been stronger. So don't.
Well, okay, but why don't we use the? Yes, you're right. We'll have a talk when we're not quite being broadcast. Instead, we could put post office in, but as Nikki says, they took a long time in the last one. But why don't we ask Jason to come back, or somebody? I prefer it to be Jason because he's quite straightforward on these things, on the 9th of February to deal with in more detail, and hopefully we'll have by then access to the second report, which the CQC and the Health and Safety Executive did, and have a really good look at what they said, and you can have a copy of it if we get it in advance. And although obviously THH is the province of Simon, Councillor Arnold and Councillor Riley, we can have a more in-depth view of that, and maybe share that with Vanessa Odlin on the Cove issue, because I thought it was really interesting, and it touches again on mental health, which again I think is becoming an increasingly interesting topic as far as COVID is concerned. And if we have we're in the middle of one lockdown, I don't know where we're going to be in the new year, but it might be interesting to have those two, and just those two in February, because it gives.
Could we ask the new chief?
Hang on. Sorry, before Simon, I had Councillor Mullally raised. So Councillor Mullally first, then Councillor Arnold.
Thank you, Chair. I know, I agree. I think you're right, and that would be interesting. The only question I had was whether it was worth us keeping these vaccine question alive, because that distribution at a local level and the strategy as to how they distribute it, if in fact it looks as optimistic as it did today, whether that's something we might want to keep our eye on locally, because ultimately the only way I see this being distributed effectively is through local authorities and the CCGs and folks. So we may want to keep our eye on that, but that might be woven into that meeting in February that you're talking about. So I don't think.
I think what certainly what I'm being told by pharmacies and GP practices is that most of them ran out early, where are we now, November, mid to late October and early November, because of a much wider take up. And they're and a lot of them are expecting, and I'm told it will have another batch coming in for mid to late November, because they're booking places for that. That's for the flu vaccine. Once we get a COVID vaccine, then I think you're right. I think that we should get from Caroline, whether she comes along to February. I mean, she'll probably come along to February anyway, but get from Caroline the take-up figures, because obviously it's going to be a graduated process in terms of categorization of peoples that are going to get it.
Yeah.
And offline, it might be an idea just to keep an eye on it and get them to send a report in to us about how that's being managed. All right, so, Councillor Arnold.
Sorry, Chairman, it was just to say, when we have Hillingdon Hospital come in as a standalone meeting, could we not ask the new Chief Executive, Patricia White, to come as well as James?
Yes, of course we can. She'll only been in post for 2 months, I guess, by then.
Which is probably a record for Chief Executives for Hillingdon Hospital.
Whether she,
I was going to say, is it going to be that Chief Exec, or is it going to be different?
Well, whether she lasts that long, who knows? But it's. I mean, we can, of course, but it will. What will happen, I'm sure, is a repeat of what we've had in the past, as you've all observed. You get someone new coming, and it's really not fair in one sense, because they say, well, we need to keep we need to get a better grip of it. We need to understand what's going on, but we keep having that. But yeah, sure. I mean, we can try. It'll be a bit of a bumpy ride for a first meeting, but then, so be it. All right. Anybody else on the work programme?
Can I just ask members whether they're happy for the next meeting on the 12th of January to be virtual?
No. I would prefer it to be live. I see some. Listen, if we have to, we have to. If we have to, we have to. But I really would prefer it if we were live. But if we can't be, then we can do it like this.
If restrictions change, then I'll come back to members to seek their opinion again.
It's always quite interesting to see what people's wardrobes look like and stuff like that. So yeah. All right. Any other issues on the work programme? No, I don't see anybody. All right. Well, in that case, I will ask Nikki to terminate the broadcast, and then we'll have a quick chat before we all head off in our different directions.